Welcome, everyone. We're really excited to see such a great turnout for today's webinar on clinical reasoning. I see more people coming in, but we are now approaching a minute after the hour, so we're going to get started. I'm Kay Connerly, and I'll be your host for today's talk. I am delighted to introduce today's speaker, Dr. Scott Stern. Dr. Stern is recently retired from his faculty position at the University of Chicago's Pritzker School of Medicine, where he was director of the medicine clerkship for nearly 2 decades, as well as director of clinical pathophysiology and the preclinical transitions course on diagnostic reasoning. He is the recipient of more than 50 teaching awards, which is a real indicator of his passion for medical education. And I suspect that many of you are familiar with his popular text, Symptom to Diagnosis, now entering its 5th edition. And this text informs McGraw-Hill's newest digital learning tool called Clinical Reasoning, where Dr. Stern serves as editor-in-chief. During today's talk, we encourage you to post questions in the chat. We have allotted time for those at the end. And I think you're all in for a really great and informative session. So let's dive right in. Dr. Stern, the floor is yours.
Thanks, Kay. Thanks for that wonderful introduction. So I'm really happy to be here. This is a topic about which I've had a passion for over 20 years, frankly. And it's how we teach clinical reasoning and how we reduce diagnostic error and how we do this better than we've done it. So my outline for the talk today is this. I want to talk about what exactly is the problem I want to address, diagnostic error. I want to talk about briefly why I think we have this problem, because if we're going to fix it, we have to get to the root of the problem of why we have it. And then I'm going to spend the bulk of the talk on how I would suggest we might go about approaching this particular problem and improving our educational system. So, just as an example, this is a true story of a woman named Jane who went to a very famous emergency room on the East Coast with dizziness and vomiting. She was seen multiple times by several doctors and told she had gastroenteritis. She went back yet again and was reevaluated, and someone thought maybe this was central nervous system problem and was actually found to have a cerebellar stroke. Unfortunately for Jane, it was too late. Her cerebellum swelled, she herniated, and she died, which is tragic. But the real problem is that this is not uncommon. The scary truth is that clinicians often make the wrong diagnosis. And I was not surprised when the Institute of Medicine came out in 2015 and reported on this. What they concluded was that diagnostic errors are a significant contributor to patient harm and have received too little attention until now, with which I fully agree. And they estimated that a shocking 12 million people a year are affected by diagnostic error every year in the US, sometimes with devastating consequences and at an enormous cost. And even if these are overestimates by a factor of 2, it's still a remarkable number of errors and remarkable consequences. So we have a problem. I would actually make the argument, having been in medical education for decades, that diagnostic accuracy is the core competency, not a core competency amongst 20, but the core competency. I argue that because optimal therapy requires it, accurate prognostication requires it, and it's the pillar on which everything else stands. If we don't accurately diagnose patients, nothing else we do is going to be very helpful. And yet we do it so inadequately, as I've just shown you. So that's the what. The why we have this problem is complicated. I'll run through some of these with you. So first of all, what doctors do is difficult. It's not simple. So, in a primary care visit or an emergency room visit, you might be dealing with multiple problems, the hypertension, the diabetes, etc. And patients also have symptoms. So if they come in with dizziness, this is the differential diagnosis for dizziness. And it's meant to be a complex slide because there's a lot of possibilities. And a doctor has to figure this out in addition to doing everything else that they need to do during that visit. So what we do is complicated. But we have educational problems. So I would argue we oversimplify disease presentation. So let me give you an example of what I mean by that. So I taught clinical pathophysiology for 20 years, and we would often teach the classical presentation. So if we talk about pulmonary embolism, we would teach the classical presentation and not all the variations of pulmonary embolism because, frankly, we'd get cognitive overload if we taught them every disease in every possible presentation. So we might tell them the expected findings are pleuritic chest pain, shortness of breath, hypoxia, etc. And the problem with that is then if patients present differently, students believe it's not a pulmonary embolism. I can't tell you how many times I've heard students and residents say, I'm sure it's not disease X because they don't have this finding, not realizing that finding wasn't very sensitive. So here's the data. And as I like to say, patients don't read the book. So here's the data for pulmonary embolism. How often do patients present classically? Well, dyspnea of sudden onset occurs in 73 to 81% of patients. Well, that's great, except it means that 19 to 27% of patients with proven pulmonary embolism don't present with dyspnea of sudden onset. Pleuritic chest pain is seen on average in about half, which means about half of patients with pulmonary embolism don't have chest pain, and hemoptysis is actually uncommon. And so what I teach patients is that, or students rather, is that the take-home message is that patients present non-classically all the time, and we should not rule out diseases simply because certain findings are absent. Now, this is not just pulmonary embolism. We have compiled this data for several hundred diseases and looked at the sensitivity of classic findings and found that very few classic findings, really about 20%, are very sensitive, meaning over 80% sensitive. Most of the findings we're teaching them about are often absent. So that's one problem with our educational system. Another huge problem is we fail to teach systematic diagnostic approaches. So we do talk about disease, and we'll tell them about heart failure, and it causes shortness of breath and edema and orthopnea, paroxysmal nocturnal dyspnea, but we don't teach them how to diagnose patients systematically. We don't start with dyspnea and say, okay, here's a systematic approach to dyspnea. How are you going to determine whether it's COPD, heart failure, pulmonary embolism, interstitial lung disease, pneumonia, et cetera, et cetera? Um, you might say then, well, if we wanted to teach this well, let's look at how experienced clinicians diagnose patients. And this is what students often learn about on the wards because the senior attendings and junior attendings round. Well, when you've done something for a long time, you tend to use system one thinking. System one thinking is rapid pattern recognition thinking. So for example, look at this picture. Most of you will recognize right away what these cars are, given the symbols that are on them. The left car on the yellow car is a Vet, and the car on the right's an Audi. And you did that rapidly, and it was easy, right? When you apply this to clinical medicine, a senior attending has all these illness scripts in their head. And as soon as a patient starts to present some information, they're immediately able to organize that information and recognize the pattern, which is great. What's the problem? The problem is when you don't recognize it, it fails. So what's this car? Who knows? And without a system to approaching it, you have no way to know what this car is or to make that diagnosis. So when you don't recognize that illness script, either because you haven't seen that disease before, or more commonly because the disease is presenting differently than you expected it to present or than you've seen before, then you're going to fail. And when system one fails, it fails. So how does this apply to what doctors are doing on the ward? So the old paradigm then is really to see if you recognize the pattern. So we ask patients to describe the symptom. We see if there's a pattern that they recognize, and the human brain does this automatically. We look for patterns. And so people will always do this, and that's fine. And we ask them to think about must not miss diagnoses. And if they recognize that pattern, to go ahead and try to confirm the diagnosis and treat the patient. But what if they don't? They're left with a not with a disorganized list of possibilities that they have no idea how to navigate. And as Joe Rensick said, they're like chickens at this point. They hunt and peck around for the right diagnosis. So they might try A and C and see if they can make the diagnosis, or A or H and I until they either stumble on the diagnosis or they give up or they say the patient's anxious because they're anxious. So that's another problem that we don't teach these systematic approaches. But in addition to our teaching problems, we have evaluation problems. So what we all know this. What motivates learners is evaluation. There's no question. And as John Cohen said, assessment is the engine which drives student learning. And all we have to do is remember that the board's part one just went from a score to pass fail because all the students were doing was studying for boards part one. So it is no matter what we say to them, it's all about our evaluation. So what is our current evaluation system? Well, we have a lot of fact-based questions, which is all students study anymore because that's how they're evaluated, and subjective faculty observations. What counts as passing is they get certain percent correct and we say you've passed. Well, that's not really so great. What about the rest of the material they didn't know? What if they didn't understand heart attacks and now they're in their clinical arenas? That's a problem. And finally, I'd argue it's not working. We have 12 million people affected by diagnostic error every year. We can't argue that what we're doing is working. Part of this problem is that the students don't really get serious, deliberate feedback when they're processing patients. So Crosby published an article where he described the feedback sanction, and that's this. If you imagine a physician seeing a patient, they make a decision and there's an outcome. If it's favorable, they're like, great, I did great. I'm going to do that again. If they find out that it's unfavorable, hopefully they'll recalibrate. The real problem is when they don't know, which often happens, and often happens to students. And if they don't know, they keep doing the same thing. So practice isn't enough. It needs to be deliberate practice that gives them feedback so they understand their cognitive errors and can correct them. And the last problem is we have to face the fact that there's a student evolution or revolution, depending on the way you look at it. So just as humans have evolved over time, students have evolved over time. And in the old days, a physician like Hippocrates might stand up and lecture and everybody was rapt in attention. Then when I was studying, we carried around these giant tomes and we read them and we underlined them and we outlined them and we highlighted them, etc. That's not the students of today. I'm sure we all have the same experience. That's not today. Today is students on the computers, and what they want is information that's fast, interactive, high yield, feedback, and prompts them for success. We might not be ready to teach that way, but we need to understand this is their expectations and we need to meet them where they are if we're going to teach them effectively. Take a breath. Now, how do we fix this? What would be some ways we would attack this? I would argue that we need to build sustainable, scalable, that's an important issue, diagnostic reasoning into the curriculum with well-articulated, very well-defined, learnable diagnostic paradigms that address all the common medical problems they're going to see so that they're competent in them, chest pain, abdominal pain, dyspnea, anemia, etc. Now, in order to do that, we actually need a new overriding paradigm. And I want to show you the overriding paradigm and then give you an example of how these work. So the first part of the student evaluation should be the same as it's always been. Data acquisition, history, physical, and labs, see if they recognize the pattern. That's going to come naturally. Think about must not miss hypotheses, test, and if you make the diagnosis, fine. But if not, instead of hunting and pecking, we should use pivotal concepts, teach them pivotal concepts to focus a differential diagnosis, limit it into much smaller groups that can then be addressed. What do I mean by pivotal concepts? Pivotal concepts are features of the history or the physical or the labs that reliably, that's an important word, reliably segregate a differential into smaller, more manageable subsets. Once we've done that on the subset, we can then focus on those diseases in detail. So we can then take a subset and look at those diseases and train them to say, okay, now you've got 5 possibilities. Does the patient have risk factors for those diseases or associated symptoms of those diseases or signs? Use that information to rank and test those hypotheses and then come to a diagnosis. Let me operationalize this with an example. So let's take transient loss of consciousness. This is the differential diagnosis, and that is not organized in any particular way, and it's hard to manage this way. Turns out there are 2 pivotal concepts in transient loss of consciousness. The first is whether the patient has had syncope or not. Syncope is when the transient loss of consciousness was due to inadequate blood flow to the brain, hypotension. And we can actually define the characteristics that help us to distinguish syncope from non-syncope. If the patient had syncope, our second pivotal point is to determine what type of syncope it was. Was it cardiac syncope, reflex syncope, or orthostatic syncope? And again, it's not difficult to train students to be able to determine which of those categories it is. What's the advantage of this? Well, each one of these groups has its own differential diagnosis. And if we can determine which group we're in, which bucket we're in, if you like, then we can really focus on that particular differential diagnosis. So if we said that this was a patient presenting with syncope, we don't have to pay attention to the non-syncopal causes. If we determined that it was, we looked further and said, actually, it looks like the patient had cardiac syncope, we can then eliminate from our considerations reflex and orthostatic syncope and now focus on the subset of diseases that's really most likely. Once we've limited it to that subset, we can then look for the signs, symptoms, and risk factors for each of those diseases and ask the students to rank and test appropriately. You could imagine organizing this in a table where the differential is on one side, the risk factors, associated symptoms, and signs on the other side. Here's an interesting observation, I think. If I was to ask a student, what are the signs of aortic stenosis? A lot of our third and fourth year students would know that. But when seeing a patient with dyspnea or syncope, where aortic stenosis is on the differential diagnosis, they don't remember to think, okay, this is on my differential diagnosis. I need to look for this sign, and so on and so forth. Or a patient who's passed out and pulmonary embolism is on the differential diagnosis. If I was to ask a student, what are the other symptoms, they would probably be able to tell me, oh, chest pain, shortness of breath, etc. We have to train them to first focus that differential diagnosis and then take those diseases and think for a minute. This is system two thinking, not system one thinking. They have to think and say, okay, pulmonary embolism, what am I looking for? What are the risk factors? Oh, have you been immobilized? Have you had surgery? Or are you on estrogen? What are the other symptoms? What are the signs? And so on. This can be trained. Ideally, at the end of this, the students and residents are using System 1 and System 2 thinking working in concert. So as they see more and more patients, which is invaluable, nothing replaces that, they build these illness scripts. This is what helps when we're experienced. But in the meantime, we supplement that with well-constructed, evidence-based paradigms that they can learn and remember that help them to navigate the evaluation of a problem when they don't have an illness script that matches it. So does this work? I'm happy to say I believe it does work. Let me show you some evidence. So first, a couple of anecdotal cases to just illustrate what I've seen. So we recently had a patient who was transferred from the ICU to the floor where we were on service. They were seen by the nephrologist and the intensivist on the floor, and they were, in the unit and diagnosed with SIADH, as you know, the most common cause of hyponatremia. They both used System 1 and failed to evaluate the patient systematically. And my resident then, when the patient was transferred to us, evaluated that patient systematically. As it happens, we'd gone through a couple days before the systematic approach to hyponatremia. And when he did that, he found out that cortisol was shockingly low and the ACTH was low, making the diagnosis of secondary adrenal insufficiency as the cause of their hyponatremia. And a pituitary tumor was discovered when she was addressed systematically by a second-year resident and did better actually than our experienced clinicians. Another dramatic case I saw recently was an 82-year-old woman with severe anxiety and depression who came in with dizziness. She also complained on her second visit that she'd had some double vision and had seen her ophthalmologist who told her she was just anxious. She absolutely was anxious. She absolutely was depressed. Unfortunately, those weren't the causes of her dizziness and double vision. And given the double vision, one could ascertain that her problem was actually in her brainstem. And when we did an MRI of her brain, this is what we found, a giant vertebral artery aneurysm that had to be resected in a neurosurgical procedure. She did fine. So that's anecdotal evidence. It might not convince you very much. So we did a multi-center study at 8 medical schools that looked at training with these strategies versus not. And what we did is we took a large group of students at 8 schools and randomized them to be trained in either abdominal pain or transient loss of consciousness. So, and then we gave them cases. So at baseline, before any training, with the cases in abdominal pain, 65% of the students got the diagnosis correct. After training, the train group improved to 92%, an improvement of 27% with 1 day of training, and a number needed to train, if you like, of 3.7 to get one more correct diagnosis. We did the same thing for transient loss of consciousness. Now, at baseline, the students did poorly because that's a difficult diagnosis to make if you don't understand how to approach it. With 1 day of training, it improved again 32%, which is remarkable. Now, you could argue, rightly so, that still only 49% of the trained group got the correct diagnosis, But that was after 1 day of training. That's a huge improvement in 1 day. We also looked at the accuracy of their differential diagnosis, and we defined that in 2 ways. How complete was their differential diagnosis, and how efficient? So you could be very complete by listing 100 possible differential diagnoses. That's not so great. You'd also like it to be efficient and targeted. Now, the black circles are baseline. As you can see, most of the students were less than 50% complete and less than 50% efficient before they were trained. And as they got trained, you can definitely see there's a trend towards moving towards more efficient and more complete differential diagnoses. So I would argue, in addition to having these learnable diagnostic paradigms that address these problems, we have to have interactive tools that support them. So I'm not going to talk too much about our tools during this webinar, but we are developing tools that can help students, whether they're seeing simulated patients or real patients, to reinforce these processes and to inculcate them so that they know when they've done these several times, how do I approach transient loss of consciousness? How do I approach headache? How do I approach abdominal pain, etc.? We also need to give them interactive encounters or simulated patients that reinforce these same processes. This can't be a random set of online cases. Rather, these cases need to reinforce the same learning objectives that you've put across as part of this tool. So if you have cases on transient loss of consciousness, they need to get feedback about how well they looked for whether it was syncope or non-syncope. How well did they gather the information about what type of syncope it was, and so on. And if you do this and you build your case set right with these learning objectives in hand, you can really improve outcomes. There are advantages of these interactive encounters. First of all, they're scalable. At the University of Chicago, when I ran the clerkship, we had OSCEs that actually evaluated how well students evaluated problems. The problem is there's only so many OSCEs you can do on 100 or 200 students. It's not scalable. You can't do them on abdominal pain, chest pain, back pain, headache, etc. for every student. You just can't manage that many OSCEs. Electronic tools are scalable. They're interactive, which students really like. It's a low pressure environment. Nobody dies in the computer, and the students like that. It allows asynchronous learning. They could do it in a classroom, they could do it at home, they can do it whenever, which is an advantage. And it allows a stepwise progression of difficulty. So easy cases are cases that are common, where patients present typically. Difficult cases are either diseases that are presenting atypically, or not classically is probably a better way to say that, or uncommon diseases, or where results are discordant because there's false positives and false negatives. All that can be built into the platform, which we've done. Again, I won't talk too much about those cases right now, so that they can go improve and get more and more difficult cases as they progress. There's an objective assessment of reasoning with detailed learner-specific feedback, fostering deliberate practice. So I want to show you an image that Raja Eli Abdunur published in the New England Journal of Medicine. And he compared just practice with deliberate practice. When people practice without that specific feedback, they may get a little better over time, but they're also likely to repeat their errors. On the other hand, if they have deliberate practice where they're getting specific feedback about where they've misstepped, that's a much better way to ensure student improvement. This focuses then the students on clinical reasoning, not just factoids. How many of your students are saying, I want to go to Q banks, I want to just run questions? That won't work for these sorts of cases where students have to really think and process the information. We need to get them away from measuring factoids or learning factoids to really understanding how to reason. And this is a way to do that. It would ensure diagnostic competency appropriate to their level. So right now, I believe that, none of us know whether our students are truly competent. I would argue that when we write the dean's letters, we don't really know when our students are going off to internal medicine, emergency medicine, and family medicine clerkships residencies, that they really know how to evaluate all the problems they're going to face. We hope so, but we don't really know. If we had a large scalable set of cases that could evaluate all these common problems, we could assure that they were competent in the problems that they're going to see. That would be fabulous. And the education literature also says that retention is superior when we do these active processes to passive modalities. And at the end of the day, we could be where I wanted when we started, which means we could not only improve classroom performance, exam performance, but we can improve ward and real life practice and decrease the diagnostic errors that are so ubiquitous in our medical environment. So I'd like to close this with giving you some concepts or some ideas to noodle on about how you can build this into a curriculum. And there's lots of options. So some options include we could just let the students do this asynchronously, do it when they want in their clerkships. You could have transition courses within your curriculum. So I had a transition course called Foundations in Clinical Medicine that was between the preclinical years, so they'd finished their preclinical years and their disease-based courses, but before their clinical years. The students are worried right now. They know they're about to go on the wards and they know they don't know how to evaluate patients appropriately. It's a great time to teach them about how to evaluate these problems. And also, another great time would be just prior to internship. Imagine your students are about to go into internship in medicine, emergency medicine, family medicine, neurology, and you could give them a course in March or April that would help prepare them not just with how to do procedures, but rather how to think through the common problems that they're going to see. They'd be very motivated because we all know they're very nervous before they start internship. You could also do this within a clerkship and distribute it through the clerkship or have a 2-week course in the clerkships. You could have it preparing for exams, and you could use it for remediation, which is a powerful use, but I would argue this benefits everyone and shouldn't be limited to just students who need to be remediated. How did I build the consolidated course options? I'll just show you how we did this at U of C for a while. So we had several weeks of a course. Again, you could distribute this over 12 weeks and do one session a week instead of building it into a consolidated time frame. But what we did when we consolidated it was each half day would be a topic: chest pain, syncope, hypotension, shock, etc. And we grouped them by the types of problems, the types of systems that they were in. The way you build out a half day then is as follows. So what I would do with them is give them a case on the topic and tell them nothing. Give them a brief vignette and say, I want you to talk to your colleagues in small groups while we're all together right now and say, how would you analyze this case? How would you think about approaching this problem in general as they do these small groups collaboration? Now, they don't know what to do right now. They're going to find that they fumble about, and that's great. You're creating a need to know. Once they've done that and they're anxious and they don't know what to do, they're really keen to learn it. And so now I can get up and discuss with them how we would build an evidence-based paradigm for that topic. Then we can go back to that case, analyze the case they've just done, and close with them, letting them do some practice cases. It was very, very effective, and the student engagement was tremendous when we did it this way. So in summary, I think it's clear. I think diagnostic errors are common and serious, and that we need new approaches to augment our old approaches to improve outcomes, students' needs, and expectations. And digital approaches do allow us to reinforce these systematic approaches if they're built properly, not just a random set of information that they see online, if they get deliberate feedback. And then we can provide objective, scalable assessment and prove that they're diagnostically competent. That's the goal at the end of the day. So I hope that was interesting to you. We would love to entertain some questions. I'm going to turn this over to Kay for some closing comments.
Thank you so much, Dr. Stern. That was really informative. And I think we have some really interesting questions that we're going to discuss now. Before we do, in case we're not able to get to all of the questions, we want to be sure to share with participants some QR codes where more information can be obtained on this topic. So firstly, here's a code for accessing a guided tour to the clinical reasoning tool that we mentioned at the outset and that Dr. Stern is the editor-in-chief of. This is the homepage you'll see when you access this QR code. Next, we have a code for accessing just more information on clinical reasoning and videos about the tool. And then finally, we will be at the AAMC meeting in San Antonio, which is just less than 2 weeks away, and we'd be excited to connect with you in the exhibit hall. Dr. Stern will also be doing live demos of the clinical reasoning tool at the McGraw-Hill booth. And we have included those links in the chat. I know we kind of went through those slides a little bit quickly. So those will be in the chat. And the slide deck and recording of this webinar are also going to be shared at the closing. So now getting to your questions, there were some interesting comments about today's students feeding patient scenarios into AI chatbots and seeking answers and relying AI to do that clinical reasoning thinking for them. So Dr. Stern, do you have any thoughts to share on how to address competency in this new world of AI?
I do, and I think that's a great question. We obviously want to train them to be able to do this in their head and not rely on ChatGPT to diagnose a patient. There's nothing wrong with looking up questions, but if we're training clinicians and physicians to actually manage patients, they need to learn these approaches. And one way to do it is that means that you have to evaluate the approaches without their ability to use AI. If you set up a system like we have with our Pi case, with our interactive cases, where they get evaluated, actually, as long as you had a secure browser, you could make sure that they actually know how to evaluate those problems. Because if if the students know that they're going to be tested on it, that's what drives their learning. And they would realize that they can't just plug everything into ChatGPT or whichever tool they want, because that's not going to be available when they're evaluated. And I think that's really important.
Great. We have another question on the topic of assessment. And again, you noted how today's students are extremely driven by assessment. Obviously, this wasn't a session where we were doing a demo of the clinical reasoning tool, but maybe you can share your thoughts a little bit more on how that assessment component comes into play with assessing using the clinical reasoning tool.
So you have to first decide on assessment what you're trying to teach. What are your learning objectives? Because that's what you want to assess. Unfortunately, right now, the way a lot of the examinations are made, they're about facts and students learn facts, but that's not really our learning objectives. Our learning objectives are to teach them how to reason through these problems that they're going to see every day, which means your assessment has to focus on that. So, for instance, the assessment of the cases has to not only include whether they got the right diagnosis, how good was their differential diagnosis, but did they gather the data to navigate the pivotal points to get to the proper diagnosis? So, for instance, in transient loss of consciousness, I mentioned that the first step is to distinguish syncope from non-syncope. And it turns out that there are three features that we can define that determine whether or not a patient had syncope. Syncope is sudden in onset, it's short-lived, and patients wake up without being confused typically. So we can look then at these interactions and see whether or not the students gathered that information and then give them feedback on whether they gathered that information. Similarly, if the next learning objective is can they identify cardiac syncope, did they gather the correct data to decide whether or not it was cardiac syncope? Did they ask the patient, do you have chest pain? Do you have shortness of breath? Do you have a history of cardiac disease? And so on. So if you can define what you want them to learn and how to navigate these problems, which we've done because we've actually been working on this for 20 years now, how to define these algorithms and these approaches, then you can evaluate them and reinforce them. And frankly, if they're not learning these pivotal problems well and not gathering the data back well, then that's affecting their grade.
Thank you. Dr. Stern, could you speak a little bit more to the topic of teaching clinical reasoning in a scalable way, given the variability amongst medical learners?
That's a really good question. So it depends on what your environment is. So in the classroom, when we're teaching it, if you had these half-day sessions I mentioned, they're working together. And as they work together, you can help to reinforce what's correct and to correct errors that they make. Um, when we do it on a simulated environment, we actually are building the cases so that they have a graduated level of difficulty. And so, as I mentioned, difficulty can be modified by including chest pain cases that are very common, like heart attack, chest pain cases that are much less common, like aortic dissection, chest pain cases that are where they present typically versus atypically, where results are concordant or not. And that way, a student could then move at their pace and get the feedback that's relevant to them and only advance when they've actually mastered the easy cases. And you don't let them advance until they've mastered it, which is a great advantage.
Great. And then a follow-up to that would be the variability among faculty and how to address that, right? Because clerkship directors all kind of have their own pace and style of instruction. How do you address that to make diagnostic reasoning, a more systematic learn for med students?
I didn't talk about that as one of the problems because it's a little, no one wants to hear this. But the fact of the matter is that our clinicians are variable. They're variable in two respects, actually. Some are great clinicians and some aren't. And some are great teachers and some aren't. So you could have a great clinician who really can't articulate how they know what they know. That's not very good for the student, nor is a clinician who's not really very good at it. And that combination really creates a lot of difficulty in our teaching environments, doesn't it? And the final problem for faculty, which we haven't touched upon, is time. Nobody has the time anymore to teach on the words the way we used to teach. We all know that they have to be done at 10:30 post call, whereas we used to round until everybody was done and until everybody was stable. And I don't want to get into the argument about the good old days and the bad old days, but the reality is that nobody has the time to teach this properly anymore. When I'm on the wards, it's such a rush. We have to first take care of our patients. That's the priority. That's the number one priority, whether we like it or not. We have to make sure our patients are well cared for. So, given that, we actually need to reinforce more than ever before these diagnostic approaches in arenas that aren't just on the ward. I love the wards. I love patients. I think there's nothing like that. But we do have these limitations on the wards. So building these course structures where they get lectures that are well vetted, we're building that into our system, where they can use the clinical reasoning tool that's evidence-based, not just what somebody thinks of off the top of their head, but based on 20 years of research so that these are reinforced, and then do simulated cases that reinforce these same procedures. That's the way we create a homogeneous learning environment for our students that's not random and based on what faculty member they happen to get on the ward and what patients happen to be present on the day that they were on call.
I love this question that just came through. How important is the physical exam in clinical reasoning today compared to, 2, 3 decades ago?
Well, we've learned a lot about the physical exam in our research of the book over the last 20 years. And what we've learned about the physical exam is it's pretty insensitive that a lot of times people have diseases and don't have the classic findings. And we know that's true. That's why we have to do tests all the time. If the physical exam was perfect, you would just use the physical exam. Nonetheless, many of the findings on physical exam are very, very specific. And we have to continue to reinforce the fact that a good physical exam is still critical because it often really changes your approach to a particular patient. For instance, if a patient had syncope and they come in and they have profound orthostatic hypotension, your differential diagnosis is completely different than if they don't have profound orthostatic hypotension. So to omit that part of the physical exam is a critical error. So we have to continue to reinforce the physical exam, but teach them how to interpret the physical exam. And what I say to students in short is pay attention to what you find, but don't put too much emphasis on the findings that aren't there, because again, they're not very sensitive. So I think we've spent too little time reinforcing the physical exam in the last decade or two, and that still has great value.
Can you share your thoughts on integrating clinical and diagnostic reasoning into the preclinical parts of curriculum versus the clinical years?
Right. So there is a big push, which I understand, to allow students to evaluate cases to get them engaged in the preclinical years so it's not so abstract. You know, biochemistry in the absence of talking about diabetes or other disorders can be pretty dry, let's face it, and students don't really want to learn it. Um, so there is value in introducing cases. On the other hand, it's very difficult to teach really good diagnostic reasoning before students at least understand those diseases. You know, how are you going to really talk about diagnostic reasoning of chest pain when a student doesn't really understand a pulmonary embolism, a myocardial infarction, a STEMI, an aortic dissection, and so on? So I'm all in favor of having a limited approach to cases in the preclinical years. But where I think this functions best is once they've learned their diseases, now focus on diagnostic reasoning, focus on those paradigms. They know the diseases, help them to navigate it. I remember very well when I finished my course on disease 100,000 years ago and writing in my evaluation, I understand the diseases now, but I don't know how to figure out which disease a patient has. Can you give me an algorithm for this? And so for 20 years now, I've been working on how to teach that. I think that's where it belongs best.
Another question that's come through is, given that a lot of medical programs or clinical curricula is very systems based, how does that sync up with this symptom slash chief complaint approach to teaching clinical reasoning?
Right. So if you have a curriculum that's system-based and it's going from nuts to bolts, meaning it's going from the anatomy and patho and physiology all the way through the pathophysiology, and you do that for cardiac and then pulmonary, and you separate them, one of the problems is, of course, symptoms are often due to diseases in more than one system. Let me say that again. Symptoms are often due to a differential diagnosis that includes more than one system. So shortness of breath could be due to cardiac problems or pulmonary problems. If you wanted to integrate this, then I would say you would teach about dyspnea at the end of the cardiac and pulmonary systems because that's where most of the meat is for dyspnea. For renal and metabolic, that's pretty easy because you could do the modules on acute kidney injury and hyponatremia and hypernatremia at the end of those. A lot of the abdominal pain would obviously follow GI and biliary tract disease. So by carefully selecting which symptom, which symptom you're going to integrate into your particular system approach, you can do it.
Great. And another question the group has is just hearing your thoughts on learning methods or, venues that may be more or less optimal for clinical reasoning. So things like, case-based analysis in a lecture hall as a group versus in simulators versus on the wards, bedside teaching, in your experience, does one work better than the other?
Well, they all have pros and cons. I love bedside teaching. The real problem is, of course, the time limitation, number one, as well as the faculty expertise, number two, and finally, what cases roll through the door, number three. So we can't simply rely on bedside teaching. You take all those together and you're not going to deliver adequately what you need to deliver. I think it's really helpful to create a need to know when I'm talking to my students. So whatever situation I'm in, I like to start by asking them questions and giving them a case vignette. It's not very good to teach in the abstract. They're much more engaged when they are learning about a particular case. So give them just enough and let them work at it. Let them realize they don't understand how they're doing it. And then let them work in groups as you work together to build a paradigm. I think that's really effective. And then show them how you would analyze that case. And then let them practice, practice, practice. And you could do this with written cases if you like, but we are, of course, building tools to allow them to do this not only online, but to get their feedback about how well they did that in a scalable way, detailed feedback about whether their differential was correct, et cetera, whether they navigated the pivotal points correctly, whether their physical exam was good, whether their history was good, whether their investigations were appropriate. So we need to assess how well they're investigating these patients. And what we do with our tool is we don't let them see the investigations, labs, procedures, etc., until they've done their differential diagnosis. Because I want them to think first and then order tests, not order tests and try to guess what the patient has.
And there is a lot of interest in assessment, and we had a question about that earlier. Can you, based on what you were just describing in the tool, and again, participants haven't seen the tool yet, but maybe you can just take a deeper dive into those metrics, right? Is it an all for nothing? Oh, they got the diagnosis right or wrong? Or can you speak to some of the pivotal points that you lean into with the frameworks? And are there smaller metrics that
Right.
can be assessed?
So it's not all or nothing. That would be foolish. Because even if they guessed the answer to the case correctly, but they didn't gather the data correctly, that's a problem. Let me give you an example of that. If someone comes in with chest pain, we would like them to take the history and do a physical exam. A proper physical exam in someone with acute severe chest pain should consider the possibility of aortic dissection, even though it's much less common, because it's lethal if we miss it. And there's a lot of malpractice suits about missed aortic dissections. So that means that examination should include bilateral arm blood pressures and pedal pulses and femoral pulses, regardless of what the diagnosis the patient has, because you don't know when you're seeing a patient what diagnosis they have. So when they gather data, I want to know that they gathered the appropriate data, not just that they got the right diagnosis. So we are assessing, I think it's important to assess, sure, was their diagnosis correct? Absolutely. You need to know that. Was their differential diagnosis correct? Not only correct, but did they use pivotal points to select the right possibility? So, for instance, if a patient comes in with abdominal pain, the key pivotal point in abdominal pain, as most people know, is where's the abdominal pain? Because the differential diagnosis for right upper quadrant pain is pretty different than the differential diagnosis for left lower quadrant pain. So if we had a case of right upper quadrant pain, it's also important that their differential matches the causes of disease that cause right upper quadrant pain. So it's fair if they put biliary tract disease and cholecystitis and things like that in that differential. It's really not so great if they included ovarian disease in that differential diagnosis or diverticulitis, which would be very unlikely in the right upper quadrant and so on. So we need to assess how well they use their pivotal points. Did they use it to navigate to the correct differential diagnosis? Did they use it to gather the right data? So once they've localized it to right upper quadrant, did they ask about the signs, symptoms, and risk factors for those diseases? So we can assess all of that and then give them feedback about how they did that so they continue to learn with deliberate practice and get better. We can also look at the accuracy of the history, the accuracy of the physical exam, the accuracy of their lab investigations, which is really important, especially when it comes to invasive procedures. So all of that should be assessed and could be assessed, and we will be normalizing the data so that the schools will understand what the average learner at their level would perform on this particular case.
Great. We have a question about spiral curriculum, which I think ties in nicely to the whole preclinical, clinical years in terms of where clinical reasoning is taught. Do you have thoughts specifically about bringing in clinical reasoning in the preclinical years where foundational information is revisited later in the clinical years? And again, I'm reading the question aloud here. For example, reviewing anatomy during a surgery rotation, or reviewing basic foundational principles to support clinical reasoning abilities. So how do those things dissect, or not dissect, converge was the word I was looking for.
Right. Well, to understand a lot of these symptoms and problems clearly, you do have to understand basic science. And we reinforce these in the lectures we're creating. You can't talk about the approach to hyponatremia and not reinforce the principles of reduced water clearance and water retention and so on and so forth. Similarly, in topics like dizziness, if you have to be able to reinforce what are cranial nerve findings, what are the findings on Dix-Hallpike or the Hin's test. And so to do this really well, as you're teaching clinical reasoning, you do bring back the basic sciences because you're using that to help them understand these pathways, not just to memorize these pathways. Similarly, when we talked about abdominal pain, we were talking about how the different quadrants are. Well, that's a simple example of anatomy being incorporated into these diagnostic approaches. So I think it's important that the lectures that they have on these topics align with these approaches and reinforce those basic principles of science because students actually like that. That's very helpful to them. They've already learned the physiology and the pathophysiology, and reinforcing that as you're discussing these diagnostic approaches is really valuable to them.
Um, Another question we have is how clinical reasoning plays into learners who may have not a good grasp of common disease presentations versus atypical presentations. I know this is a topic you like to talk about, and
Right. So there's many more diagnostic errors that occur because patients present atypically than because they have zebras. And that's a big problem. And so I remember myself as an intern, a patient who came in with several months of shortness of breath. And I was trying to figure out, my attending kept saying, well, do you think it's a pulmonary embolism? And I kept saying no for all the reasons that I know better now. It wasn't acute, she didn't have chest pain, et cetera, et cetera. And when we couldn't find anything else, a VQ scan showed that she had like 50 pulmonary emboli. So it is something that we have to reinforce. And so that's again the advantage of having scalable tools so they continue to see cases, not just the typical ones, but the atypical ones. And when we talk about clinical reasoning in general, when we teach them about this topic of diagnostic reasoning, we have to reinforce what I showed on that pulmonary embolism slide, that these findings are not sensitive and they should not eliminate diseases from their differential diagnosis because a patient is not presenting typically. We just have to reinforce that at every time we get. I remember actually when I was an early attending, and before I'd learned all the data about this, I'd often have residents who would tell me how sure they were that a patient didn't have several diseases that were still on my differential diagnosis. And I remember thinking, how are they so secure on this? Is there something wrong with me that I'm not secure about cutting those things out of my differential diagnosis? And over the years, I found out that periodically they did have those diseases because of what I've just explained, that those findings weren't very sensitive. So I actually tell students and residents every time they want to say they're sure a patient doesn't have a disease because they don't have a finding, they should instead put their hand over their mouth and not say it because it's usually wrong when they say that.
I think we have time for one or two more questions. Do you have thoughts on the challenges that learners have with synthesizing all the information that they need to collect from a patient? So, the history, the investigations, and then taking all of that and putting it into a thoughtful, coherent differential.
Sure, and it's a bigger problem than it ever was, frankly, because of the way that students are so test oriented now. Frankly, we have this problem everywhere where students only, instead of studying books or going to lectures, they're doing Q banks and they're memorizing facts. We have more of a problem with this now than we used to have before. There's no question. I think the way to combat this is to have complex examinations, even in the preclinical years, that test their ability to navigate and really think about these problems. Um, I actually think schools should require attendance to lectures because I think not doing that is a big problem. We have to somehow, we have to reward behaviors where they're learning things properly instead of rewarding behaviors that are just factoid-based examinations. As long as we have factoid-based examinations that reward that behavior, we won't win this. And it's gotten worse and worse.
And I think that aligns perfectly with one last question we have, which is how that all fits into the topic of premature closure and your thoughts on that and the importance of balancing that with teaching clinical reasoning.
Right. I think the simplest way to describe the error clinical of premature closure is you really don't know what a patient doesn't have that you could cross it off until you know what they do have. So until you have the data that confidently makes you confident that you have the diagnosis, you should always consider the other diseases that are on your differential. There's a lot of, there's false positives and false negatives on labs. There's false positives and false negatives on the history and on the physical exam. And students have to learn a little bit of humility. I like to tell them, when you get information, it's rare that you can cross something off your differential, but you can move it lower or higher on the differential diagnosis. So actually, one of the advantages of the work that we've done over the 20 years is that we know the accuracy of the lab's history and physical in detail. So when we make these paradigms, we can line them up with what the data shows, not just what we imagine the data shows.
Great. Well, on behalf of McGraw-Hill, thank you everyone for joining us today. Thank you, Dr. Stern, for that talk and for the discussion. And we hope everyone found the session to be informative and valuable. And we hope to see some of you in San Antonio at the AAMC meeting. Have a great afternoon.
Thank you.